I think we can start the session. I hope others may join us along the way as we continue. My name is Sandy Matlam from ECHO-Eswatini Hospice at home. I hope you get me. May I request that you introduce your name and the place where you are joining from, and also, if possible, your email ID on chat if you are joining with other people with you. So if you are a team of 10, may you introduce your 10 members. Who are they, their names, and their positions in the area you are joining with them. So during the session, we will request that we keep our cell phones in a silent mode, or if possible, vibration. At this time around, I will request that we introduce ourselves. So, as who, what is your name and where are you joining from? So I will start with the Melusi. Shomwe, may you kindly introduce yourself? Melusi, may you join with your audio so we may be able to hear you. Meantime, I will request Nobumele Dami to introduce yourself.
Good afternoon, guys. Sandy, I have already written in the chat box.
Okay. Thank you. You are joining with your team. Yes, may we request Sonam Panami?
Yeah, hello everyone. Am I audible? Am I audible to all of you?
Yes,
Yes, Sonam, you are.
Hello everyone. I'm Sonam Parnami. I'm part of the training team at ECHO India, and I'm here to observe the session. Thank you.
Thank you, Sonami. May we ask Fanelin Galala?
Hey, good day, everyone. Am I audible?
Yes, you are audible.
Okay. I am Fanale Nizgalala. I am joining from the University of Eswatini, Faculty of Health Sciences, Department of General Nursing. I'm joining just to observe and listen. I'm a lecturer in the department.
Thank you, Mr. Zgalala, for joining today. May we request Magazonda Kamete to introduce yourself. Kamete. For the sake of time with me, I'm joining with Mercy. I'm joining with Mercy, our social work, who will share a presentation with us today. And I'm hoping others will join us as we continue. Today's session will be looking at the ongoing goals of care. Let me just say that in our last session, we were looking at introduction to the ECHO project or the ECHO program itself, for what is it all about and its benefits to us as healthcare workers. And then we had a case from RFM Hospital, which was a patient, a married male, 47-year-old, with Kaposi's sarcoma advanced stage, who was on the deteriorating phase of palliative care with moderate to severe pain, with a smelling watery discharge. And the patient was introduced into palliative care on February 2022 and has done chemo in the past. And the patient was on ART. The patient was presenting with depression and anxiety, social issues, and then the patient has his mother with diabetes mellitus, and his sister. The patient was referred to Manzini Hospital for chemo, and we discovered that on the assessment of the patient, the goals of care and advanced care directives were not attended to or discussed with the patient, as assessment was going to be done on next visit. During the session, it was revealed that the patient was already lost on tracking. So the RFM Hospital palliative care tried to reach the patient via telephonically. They were not able to reach the patient, so the patient was lost. On recommendations, it was recommended that the patient may be referred to social work for assessment and further management, and that the goals of care will be explained with the patient and the family, and the family should be involved, as at this time only the patient was met, and the plan for referral was only discussing the patient without the family involvement. We also encourage the issues of spiritual and culture issues assessment, and the issue of ethical issues, especially with the treatment of chemo. And then we also recommend the issue of adherence, counseling and support, as the patient might not be adhering to the chemo itself. So that was happening in previous sessions. So today, we are going to look around on the issue of ongoing goals of care. So we have a case which will be a follow-up from Manzini Hospital. So in this meantime, I will request Ms. Shabamu to take us on the overview of goals of care, so we may know how goals of care looks like and how we can maneuver around doing goals of care. Then from there, we will then look around the case presentation from Manzini Hospital. May I give this opportunity to Messi to give us a didactic session.
Thank you, Mr. Matamu. Good afternoon, colleagues. My name is Mercy, as I've been introduced, and today we're going to be looking at ongoing discussions of goals of care. So as part of our objectives, we're going to explain the importance of ongoing discussion goals of care. We are also going to discuss questions about ongoing care. We are then going to demonstrate how to address changes in goals of care. So the importance of goals of care discussion to be continuous or ongoing is that the patient's priorities and needs usually shift constantly. So as such, a constant update is then required, which then results in changing and evolving care plans. Systematic meetings to discuss the patient's concerns about the shift in needs and priorities are then important. So ongoing discussion goals of care in the disease process actually promotes better outcomes, which include a more informed choices, better palliation of symptoms, and more opportunity for resolution of issues. Ongoing discussion goals of care actually do focus do focus on the disease progression of the client. And they also focus on, or they are more based on the lack of further curative treatments. These are basically situations where we find ourselves, because in our last session, we were talking about advanced care planning. And then from advanced care planning, we said that we need to continuously have discussions to see if there are any changes or concerns from the client. So these issues may arise with the disease progression or lack of further curative treatments. It could also be issues of lack of any treatments to stabilize the disease. It could also be transition, where at a point where the client transitions to comfort care or end of life care, or at a stage of terminal prognosis. So in order to go about these discussions, we actually require a lot of skills, which we have actually discussed in our previous sessions, but I will just quickly go through them so that we can understand how we can have our ongoing discussions. As we can see, there's communication at the top. So with ongoing discussion goals of care, we need communication skills, which will help us, or which will guide us on how to impart information to the client, which skills we could use to gather information that we need, and how we can achieve such by using listening models. The last time we discussed 4 listening models. And then as we go about the discussions of goals of care, we require that we conduct, or we are required to conduct family and team meetings, which are very important because they help us in team collaboration, and they also help us in issues of conflict management. And in these team and family meetings, this is where you decide with the client, or you identify with the client who should be a part of the meeting, and you consider where to hold the meeting and how long the meeting should last for. And then you also avoid common mistakes, which usually occur as we conduct family and team meetings. With these discussions, or should I say ongoing discussion goals of care are continuous of what has been happening or what has been discussed during breaking bad news. So with breaking bad news, it could be when we are giving diagnosis, or it could be when we are communicating the prognosis with the client. It could be a state of clarifying goals, determining advanced directives, talking about dying, loss, grief, or a point of pronouncing death. So as we continue with the ongoing discussions of goals of care, we continuously consider ethical issues and management of those issues, where we cover aspects of autonomy, which is basically respecting the patient's self-determination and promoting an informed consent, where we also look at aspects of beneficence and non-maleficence, where we promote the well-being of the client by ensuring that any form of treatment and care they receive is patient-centered. We also look at aspects of we promote justice, which is basically the fair distribution of resources for all clients and an equal access to healthcare. And then there's also the virtue-based ethics, which focuses more on compassion and trustworthiness. So with our last session, we were focusing on advanced care planning, where advanced care planning focused more on discussions and reflections about goals, the values and preferences for the future treatment in context of anticipated deterioration. And what is very important with advanced care planning is that these planning should be an ongoing process of the information, and it should be reviewed and updated regularly. It should also be integrated into the routine of care for the client. It should be appropriate and staged to the client's health. So there are certain questions, these are just a few questions that we selected that we can actually use when we are having our ongoing care discussions with the client. So some of the questions that we can ask are, which symptoms bother you the most? In this way, this is a very open-ended question where the client is able to actually lead the entire conversation by telling us which symptoms are bothering them the most, not what we think bothers them the most. And then we could also ask questions like, if you were not ill, how would you spend your time, or how would you like to spend your time? So here we are starting to understand or get a better picture of what the client was able to do in the past and what really concerns them about probably the inability to do those things. And we are even able to get a picture of how then we as the healthcare team and the family members can actually help the client, supporting them in certain ways that they can no longer assist themselves in. And then we also look at, or we can ask questions of how are things with the family and friends. This is where we are looking at issues of support, where we are looking at how the family is actually coping with the entire situation. We can also ask a question of, do you have a preference for where you spend time? It could be at the hospital, at home, or for health appointments. So with these discussions, we are able to get and respect the client's decision to say they want to be in the hospital setting or they would like to be taken care of at home. Another question that we could use while having these discussions is asking, have you been feeling worried, sad, frightened, or frightened about your illness? So here we are trying to get how the client is feeling, their emotions, if the client is anxious, and if the client is probably depressed, so that we can know how to go about supporting and helping the client. As we said that goals of care could probably change due to prognosis. So we usually have these meetings not just once. It doesn't happen only at advanced care planning only or the first ongoing goals of care session. But whenever we meet the client, we are always checking if the client is still okay and how the client is actually coping with the changes. So some of the questions are that we could ask if there's any change that has occurred. It could be a positive or a negative change. So then we could ask, what do you understand about your disease and current condition? So here we are able to get the client's understanding about what's going on with them. We are also able to ask questions about what concerns you at this time. So what concerned the client the last time could possibly be different from what worries or concerns the client at this point in time. So it's very important to continuously check. And then we can also ask questions of, have you given any thought to what kind of treatment you would want and not want if you become unable to speak for yourself in the future? These are some of the things that you probably have discussed with the client before, but we are always checking if the client is still maintaining the same story or version, or if the client wants certain changes to happen. We continuously check how the family is coping with the changes. Like I said, it could be a positive change. It could also be a negative change. So we want to see how the family is coping, because we usually put emphasis on the healthcare team working together with the client and the family members. So we do not leave them out even at this point. And then if there's anything that the client is concerned about in relation to their family members, we could ask questions like, would it be helpful to have us talk to them with you about changes and goals? Because we want the clients to be at the front of everything, but although the people that are supposed to play a role in supporting the client are also supposed to be on board. So this is the end of today's presentation. Thank you.
Thank you, Mercy, for such a wonderful presentation on goals of care. What I've picked up is the issue of communication is the backbone of palliative care. Without it, we cannot be able to give care to our patients, and we cannot be able to satisfy or meet the quality of life that they define. So with the ongoing goals of care, we are able to reevaluate and be relevant to the patient at all times. And it helps us to be always aware of what the patient is going through and what the patient is thinking. While we are seeing that my patient decisions and interest and perceptions, they change now and then, so we cannot assume at any point if that's what they want. So we need to keep on checking. Another thing is that it helps us to know when to stop and when to continue with other activities. So I will give the floor this time to ask any question or to add any comment. You are also free to raise your hand or so I can recognize you, or you can put your comment or question on chat. So what do we think about the goals of care? Goals of care are a build up from the last step we talked about. So we are treating a certain series here, which is saying after we've broken the bad news, it's good to sit down with the patient and plan for the future, which is through the advanced care planning ahead before other things are happening. Then once the advanced care planning, which is under the goals of care planning, then we do the ongoing follow-up. Now we are looking today on what do you do going forward after we've established the long-term plan. How then do you go around every day reviving this long-term plan? So anyone with a question or comment, I will open that for now. Anyone with a comment? Okay. In the absence of okay, I see Mfaneleni, may you share?
Thank you very much for the presentation. It was really comprehensive and insightful. But I just want to share the fact that indeed the communication is key when it comes to these goals of care. Actually, I've worked in an ICU setting for about 6 years, and I've realized how much communication is key when it comes to the issues of advanced planning, advanced care. And I would also just wish to highlight the fact that these things are important, that they are integrated and be part of the ongoing care, because you find that if it's not part of the ongoing care that is included in the SOPs of the setting, you find that it depends on whosoever is there at that point in time. So we find that it's not standard as part of the practice in the case, yet it's very key in this aspect of goals of care. Thank you.
Thank you, Mr. Zigalala, for such knowledge and comment. It's well noted. It's something that we need to learn. One said communication, it's a learned skill. So practice, you become perfect, especially the communication. In our first presentation, when we started this series, we looked at the core components of clinician communication. One involves that our duty, you may be tempted to sway the patient to something or convince them to do something, but our duty is to share the information and be there for the patient. So always be clear of what is happening and not lie to patients. So We understand that sometimes patients will refuse to get the truth, but our duty is to tell the truth and in an ethical and human way. Thank you so much. Is there anyone who wants to add on this one? Then we move to our today's case. Okay. If anyone will need to share, you may share it on chat. May I this time give Manzini Hospital the opportunity to share today's case, so we may work on it. Over to you, Nombumelelo and team.
Good afternoon, everyone.
Yes.
Yes. Yes, it's Nombumelelo and Tim from Manzini Government Hospital. Maybe for clarity, it's not a new case that we're presenting today, but it is kind of a follow-up case that we presented, I think, on the 29th of June.
Okay.
Yes. So for the benefit of those who maybe could have forgotten, and for those who have not joined initially, we'll go through just a brief history and kind of get into the goals of care. So we had a 43-year-old female client who was diagnosed with cervical cancer. So currently it's a recurrent diagnosis and it's advanced. Are we still together?
Yes, I'm trying to open the case on
To share the screen.
Yes,
Yeah, please try to share the screen.
Give me a few minutes. It is giving me hard time.
Okay, that's fine. Like I was saying, this one was diagnosed around 2019, while you're still trying to share the screen. She was diagnosed 2019, and at that time it was stage 1B. So ordinarily she should have benefited from a total hysterectomy, which was done in 2019. But for some reasons, it didn't work positively because she showed up later. I'm still trying to access your screen.
Oh, continue. Don't mind, I'm working on it.
You're working on it. Okay, I was just giving a brief overview of the case, but then let's just continue to present as it is. Yeah. So the main problem or concern that we had about this patient when they actually came, please note that currently the client is not in the facility, but she's being followed up at home. So when they came out to the facility, we noted that the family members, the sisters, the brothers, the siblings, most of the family members felt like we should be moving her around, trying to seek second opinion, trying to find out what actually exacerbates the condition of the client. So we had to sit them down and explain the prognosis, discuss the prognosis with the client, together with the family. Another concern is that the client was experiencing severe pain, and there was an issue of a vesicorectal fistula. There was an issue that the client was no longer keen to stay with the biological family now. Also, she wanted to remain at her aunt's residence until she died. Actually, the first thing she said, if we cannot keep her within the hospital until she dies, then she rather stays with her aunt until she dies. She's not willing to go back home, not while she's still alive. And also repeat that, please note its query, querying an issue of gender-based violence as stated by the client. However, we noted that when we try to dig deep, the client doesn't want she doesn't want us to actually discuss it with the family. So she kept saying that the father pulled or drove a gun towards her. There was just a misunderstanding when the father pulled a gun towards her. But then when trying to find out if we can actually dig deep, she didn't want to talk about that incident that much. But then you would pick Emma emotions from time to time when she actually relates what was happening. So the chief complaint at the time, it was a pain that was scoring between, actually the pain fluctuates depending on a number of issues, but the pain fluctuated between 6 and 8. Then she had EDVT, which made her immobile. So basically she assumes one position like day in and day out, be it your night, be it morning, she just assumes one position. And she doesn't want to go home. That was so bothering. That was so bothering according to us, because we have always viewed the family as so supportive. Then when actually engaging with the client, we realized that she feels like what we termed support, it was actually their family actually monitoring her, making sure she remains sedated. That's what she actually said. Then significant medical and surgical history. I had already mentioned that this one was diagnosed with cervical cancer stage 1B around to 2019. She did a hysterectomy 2019 May, and a CT scan was done afterwards around December 2021, which revealed that there were traces of cancerous now. So again, the client was put on chemo now. That was 2021 January. She was put on paclitaxel and carboplatin. She did 6 cycles. Then she was sent for radiation afterwards. After the radiation, then patient was supposed to come for follow-ups to the facility. It was Mbabane at that time, but she didn't come as scheduled. However, she only showed up to the facility when she had already developed DVT. So around March 2021, then she was put on she was put on high-dose warfarin for quite some time. Unfortunately, she then developed heparin toxicity. So until now, the patient still, she just moves between heparin toxicity and we re-challenge the warfarin. Then again, she develops warfarin toxicity. 2021 October, a CT scan was done again after she had developed the DVT. So the main reason she returned to Mbabane, it was for the DVT. But then when they did a CT scan again around October, it confirmed a recurrent cancer, which was advanced. Are we still okay?
Okay.
Hello?
Yes, we are okay. We are listening.
Hello.
Okay. Please tell me, if I'm moving too fast, please tell me. Hello?
Yes, you can continue.
Okay. So after that CT scan that confirmed a recurrent and advanced cancer, she was put on palliative chemo, and it was explained to the client and together with the family. So we continued with palliative chemo to a point whereby the entire team felt like continuing with the chemo, active chemo, it's no longer beneficial to the client, but rather doing more harm than actually assisting the client. So then the facility decided to stop the chemo. So chemo was stopped June 2022. However, the client was expected to continue with supportive care. So the family, the clients, they were involved in discussing this. So they know that the client has to come to the facility to continue with the zoledronic acid as discussed every 2 months. Then they know that they have to continue with the warfarin, but it has to be taken only 2 times a week, which is Mondays and Thursdays, which they are still doing. Then relevant past medications, the Clexane, she was on Clexane, she has been on warfarin, she has been on paclitaxel carboplatin, she has been on bevacizumab, gemcitabine, she has been on pethidine and Zometa. So the reason I keep saying she has been on paclitaxel is because the chemotherapy, the active chemo has been stopped now. So she's no longer on any of this. The other time when we presented, she was still on bevacizumab and gemcitabine. So currently she is not on any active chemo. It's basically supportive care. Then current medications that she's on morphine, which she doesn't take as per prescription. She only takes when she feels like severe pain. But otherwise, the client feels like the morphine is causing more problems for her. So she still prefers sticking to diclofenac. If there is need, she still prefers sticking to the amitriptyline. The bisacodyl she only takes if she would take the morphine. And the warfarin, they still continue with warfarin, the zoledronic acid, they still take, but since discharge, she hasn't come back because it's still within the 2 months. Then social history, obviously for obvious reasons, she's not working. Otherwise, her occupation, she said she's a beautician. She went until tertiary. Socioeconomic class, she's middle class, and she is married, yes. Even though sometimes she would tell you that she doesn't even consider the marriage, but legally so, yes, she's still married. And at some point she mentioned that at some point she used to do a bit of clubbing, alcohol, smoking, until she got sick. But since she got sick, then she hasn't been taken. History of same condition within the family, yes, the grandmother did have cervical cancer as well. Advanced care directives, they do not resuscitate and whatnot. It hasn't been done. This one is a facility issue, so it wasn't done. Advanced decision to refuse treatment, it wasn't done as well. However, we managed to discuss the issue of a proxy decision maker, to which she said she prefers it would be the aunt firstly. Unfortunately, the aunt she resides in South Africa. So if it's not the aunt, it has to be the daughter. And please note, with the daughter, the daughter, she uses the same surname with the mother, which she says she prefers it done that way. Mental capacity was assessed, a mental status evaluation was done, a PHQ-9 depression assessment form, it was done. We'll get to that. Comments and concerns, yeah. The mental status evaluation, it was done. Firstly, it was the nurses who did it, and also we seek a second opinion from the senior medical officer because she has been practicing the National Psychiatric Hospital, and she has passion anyway. So she did the mental status evaluation as well. She did a depression evaluation as well. So we only noted that during the speech is a bit slow. Otherwise, there is coherence. Otherwise, thought form is okay. Content is okay. There is nothing questionable about that. It was just the issue of the rate of her speech. So what we picked during the evaluation is that the client does insist that the father pulled a gun towards her, and that the family actually keeps her sedated. So the reason we're picking this one, or we're mentioning this one up here, it's because one would argue that the client has probably delusions or something. But then one would argue, could say, what if it really happened? But then the question is, okay, maybe the concern is, why is it that the client doesn't want this issue brought up with the family? So it could be a number of issues. So the issue was handled by the social worker as well. The SMO is involved. Yeah, we're still trying to figure out how best can we handle this one. Otherwise, it's a potential GBV case. But then, amongst other things that we considered is that on discharge, the client wouldn't be going back to the biological, like her parental home. She is currently staying with her brother at her aunt's place. So the threat is not so, it's not so much. So while the social worker and the team is still handling the issue of a potential GBV case. We also noted that the little interest and little energy could not necessarily be because the client is undergoing a depression, but it could also be as a result of the disease process. Review of systems, client is currently home, please note that. So the vitals that were taken and the review of systems was mostly done while the client was under admission. But currently the client is at home. So the last temperature that was done, it was 35.9, blood pressure was 102 over 66 millimeters of mercury. Then pulse was 92 beats per minute, respirations were 20 breaths per minute, and the SpO2 was 99% at room air. Then please note that with the pain score, okay, we're still following up this client. I will get to that. We're still following up this client at home, and we will discuss why we're still doing that. Otherwise, the pain score, please note that since the client has been home, she was checked on the 21st of July. So the client said it's around 6 and 8, but then the brother, it's a biological brother anyway. The brother says he thinks that the pain is a bit to a lesser extent than it used to be. So the reason he said that the client was actually able to kind of remain calm for quite some time, and the sleeping pattern was actually improving. So when we actually followed up on the 25th of July, the pain score, it drastically dropped. Oh, should I say drastically dropped? But the pain control improved because the score, it went down to around 3 to 4, which is, according to them, it's not something that's really bothering them, considering what she has been through, because most often she would be screaming and requesting for a lot of other things due to the pain that she was experiencing. So since the patient has been with the brother at her aunt's place, the pain has actually gone down to around 3 and 4. ECHO functional score, client is currently, she's confined in bed. So, okay, this one is, according to the assessment, she's ECHO 3. But most of the time she's in bed. Yes, she is able to sometimes stand up for a few minutes, but most of the time she is in bed. Symptom assessment. The pain, like we had said, it's got 6 to 8 when we discussed this, but then it has moved down to 3 and 4. There is no dyspnea. Anxiety, we didn't pick much of the anxiety. Agitation, yes, to some extent. The depression score, like I was saying here, most of the boxes that she ticked, we feel it's not necessarily due to depression, but it could be as a result of the disease progress. But we are still monitoring the client. Drowsiness, I think the drowsiness has greatly improved. So she would be drowsy, but not most of the time of the most parts of the day, like she used to before. Nausea and vomiting wasn't reported. Anorexia, she doesn't have anorexia per se. It's just that when she eats, she takes quite a long time, obviously. And also she usually has dry mouth, which may also exacerbate the issues of eating. Constipation, yes, she would have constipation. When she has it, it becomes severe, but sometimes because she doesn't take much of the morphine, she doesn't experience constipation. Dry mouth, yes, she does experience dry mouth quite a lot. Poor mobility, yes, it's overwhelming because most of the time she is in bed and basically due to the DVT. Okay, the labs we did the other time, we discussed them. I don't know whether I should go through them again. But of note, the INR, it had improved because at some point it was less than the normal range, but around May it had improved. MRI, the imaging special investigation, the MRI, which was done 2021, it showed soft tissue thickening and enhancement. It also showed destruction of the ischial bone. Then a CT scan that was done 2020, it showed there was a CT scan that was done 2020, another one that was done 2021. Then the latest one, 2022, it showed bone destruction and soft tissue mass due to metastasis. Then there is also a right thigh swelling due to lymphedema. Then plan, it was when we discussed the other time before we had actually not decided whether we are discharging at that time, but then we had to come up with a discharge plan, which included that we had to stop the active chemo, which was stopped. Then client was discharged. We continued with supportive care. The reason we're still following up on this client, before we link our clients to home-based care, we normally check with them if they are comfortable. So for this one, I think the actual issue here is that the client is moving between denial and bargaining. She's still not sure where she is, because at some point she would ask you about the chemo, yet it was discussed that we are stopping active chemo. So for this one, we're still following up with her because she didn't want to be linked to home-based care. And one of the reasons she cites is that she is still fine. She thinks she's doing fine. There is no need to refer her to home-based care. So we're still walking her through the entire process until such time that she agrees to be linked to home-based care. In the meantime, we're still following up. All right. Then the pain management. I think we are happy with the pain management. We just realized that it was more than just physical pain like we always thought, but it could have been like an emotional distress or spiritual distress or whatsoever. But now that she is happy where she is, I think the client is doing quite well. The pain, it is mostly controlled because they say during the day she would remain calm. So what they normally do is just to give her something that will keep the energy up during the day so that she doesn't get to sleep during the day. And she spends most of the night sleeping. So as far as the pain management, I think we are fine with that. Then with the issue of the DVT, she still continues with the warfarin twice a week, but we noted that the swelling is not going down. However, we realized that when we engage with the aunt, and at some point she would try to convince the client that the swelling was going down, particularly while she was still under admission. She would convince the client that, no, I can see the swelling is going down, the leg is shrinking and all that. But on ongoing assessment, it's not going down. It's still swollen. But however, she still continues with the warfarin, and they understand why exactly we should continue with the warfarin and why exactly we cannot give it on a daily basis. Then she still continues with the Zometa like every 2 months. However, we're still within the first 2 months. Otherwise, while she was under hospital care, she would continue with the Zometa. A family meeting was held with the family. Unfortunately for us, for this particular meeting, the clients didn't want to be in the same room with the family. So we had to have discussions like separately. We had the first discussion, it was the client, the aunt. She's comfortable being with the aunt. But then she said she wasn't keen to be in the same room with her family. But then when trying to probe some of these issues or bring some of these issues up with the family, the elder sister would from time to time say they think her decision to go stay with the aunt, it's basically a question of preferences. They didn't pick anything bizarre within the family. So she kept saying they think it's just a question of preferences. Well, to us, it sounded more than just a question of preferences, particularly considering the fact that the client, she's currently doing quite well being at her aunt's place. And please do note that at the residence where she stays in, it's a rented flat. It's not like a home situation, but she prefers being there than being in the comfort of her home. Then, follow up at home until she's okay, being linked to home-based care. We're still doing that. And pain is resolving. I think we are quite well. We are quite happy with how the pain is controlled. The interventions by the family also, but we think we are happy with how the pain is being controlled. I think that will be it from our side, not unless there will be additions from the team. Hello.
For the presentation. May I this time around open for comments and questions the team may have for Manzini Hospital case? Any questions or comments we have for Manzini Hospital? Okay, I have Mercy here for a question for you.
Thank you, Mr. Mashamu. Thank you, Tandazile, for the case presentation. I have a question about the family meeting that you were saying was conducted. I wanted to know if the client consented or did give the names of family members that she would want to be a part of the meeting.
Sorry?
I was asking if the client did consent to the family members that attended the meeting, or did she specifically give you the names of people she was comfortable or family members that she was comfortable that would be a part of the meeting, in as much as she decided to be to meet you with her aunt, but the others that were present.
Okay. Before we actually got into the issue of the meeting, I think we missed this one. The first thing she did, she just cut everyone from the biological family, apart from the aunt. She cut them from coming to the facility, just everyone. So she didn't actually specify, I don't want to see this one. I would prefer seeing this one. She cut every communication from from the biological family. So we only had a discussion with her and the aunt, but then discovering that we cannot just leave the family who had brought her into hospital. Then we felt like I also have a family meeting with the others, but of course it was after a discussion with the client. We discussed with her that we need to have a family meeting. She said it's okay, but then she's not going to be part of that meeting. So she didn't actually specify which family members she would prefer to have or whatnot. She basically said she doesn't want to have them at that time.
Thank you.
I don't know whether that's...
No, thank you for the clarity. I think I'm answered.
Okay. Please, okay, while we've been visiting her, we've been checking how they have handled the issue of family visiting her, taking calls from them. And we discovered that, okay, currently she is with the brother, it's a biological brother. So she said she does allow them to come visit, but they don't stay for long then. And also they say that sometimes, even if they do visit, when they come in, she would be like, she wants to sleep, she wants to sleep. So, but then they are trying, like the family is trying to kind of work on this one. So the family does go to visit her wherever she is.
Okay, and then the second question I have is about the GBV query. As in, how did the issue come about? How did you pick that up?
How did we pick up the issue of the GBV?
Yes, I understand the query, but like, yeah.
Yeah. Actually, on the last admission that was done on the 16th of June, when she came in, there were no much issues other than the issue that she didn't want to be at home because they keep her sedated. She strongly believed they wanted her dead. Then on that same admission, she did mention that the father actually drew a gun towards her. So that's how we got to know about it.
Okay. Thank you.
Anyone else? Thank you, Mercy, for that question. Anyone else with a comment or question? Anyone with a comment or question? Here's the case for Manzini. Anyone with a question? Okay. In the absence of, okay, I see Marika Mete with the question. Marika Mete, you may.
Yes, thank you. Thank you. Thank you, Mhlangu. Thank you, Mpumi, for the presentations and to Mercy too. My question was on the issue of morphine. Yes, Mpumi said the patient okay, she said she had problems with morphine, but I didn't get what problems were. Like, what is her real problem with morphine?
Okay, with her, the issue was the severe constipation. She would say that it just gives her like more pain than any pain she has experienced. So she was so reluctant taking the morphine because it causes the severe constipation. At some point, the client was said to have a vesicorectal fistula, but since she has been home, she has been passing stools and that thing has been coming through the vagina. So maybe, well, I don't want to insinuate that it's because she's no longer on the morphine, but then to some extent, she felt like the morphine is causing her more constipation she could bear than anything else.
No, thank you.
Thank you. Anyone else with a question or comment? On the issue of the brothers visiting, did you say that the patient wants them to stay long, but they are not willing to stay long?
Okay, the family, she is actually, the caregiver currently, it's a young brother, a biological brother, and they get along so well. But the others from the family, they do come see her. But even if they are around, the brother said that she would from time to time say she's feeling sleepy, she wants to sleep, she wants to rest. So it's not a question of whether they want to stay longer or not, but even if they are there, but she'll be already complaining that she wants to rest, she wants to sleep. So she doesn't actually overtly say, I don't want them to stay long or whatsoever, but the actions speak actually louder.
Okay, thank you. Any question that we have? So my question is, has he ever stated the reason why he don't want to see Ama families, at which family side is not willing to meet? And the issue of what the family is saying in terms of the second opinion they are looking for, and the issue of what is this? Yeah, maybe if these two, the issue of the second opinion that the family is looking for, and then
Okay. What she normally says, which puzzled a lot of us, because ordinarily we would have perceived the support she was getting from the family as like the best anyone would have ever asked for. But then according to her, she thinks it's not just the support, but they're monitoring her. They just want to keep her sedated. They just want her dead. That's what she actually claims. She thinks more than being supportive, they're just monitoring her, ensuring that she remains sleepy and drowsy. Actually, she believes they wanted her dead. That's why she thinks she's not comfortable having them around. At some point, she even said their father had given them some concoction to use, but they are not using it because they do not even trust it. All right. Then the issue of the second opinion. The client, it's not like she really wants to be seeking a second opinion. She understands what's going on, but then it's the sister, like I would be specific, it's the elder sister who felt like, because there is this DVT, can we be sending her to maybe a cardiologist or whatsoever? Then we roped in Dr. to actually explain what's actually happening with the client, but they then should keep insisting that she feels like we need a second opinion and stuff. But then the client wasn't actually keen to be moving up and down. Actually, she wasn't keen to have them around.
okay. So I'm getting you when if you are saying the patient is refusing to see his own biological family members.
Yeah.
So what about the Spanish, is it a paternal or what?
Yeah. The Spali. You know when I asked about the Spali.
Yes, each of the friends, so the other family of Mary, what is happening about them? Where are they her friends? Are they close to them?
Okay, let me start with the Spali. With the Spali, after they got married around 2010, she said the very same year things went south to around not sure which year. Sibali lost umsebenzi due to, according to her, due to fraudulent activities. So Sibali has been all over the place, but he hasn't been so much supportive. Like since the clients came into our care, we have never seen Sibali. So even if you ask the client, she will tell you, I don't know whether I'm married or not. I've got nothing that ties me down to that person except for that legal paper. Otherwise, I'm not her responsibility. And for the longest time, ever since we have known her, the only people that have been visiting her, it was the people from the parental home. The in-laws, we have never seen any. We have never seen the husband. We have never seen any of the in-laws.
Okay, thank you. The reason we're asking, just want to understand what is happening with this patient. Thank you so much. If anyone with a question or a comment for Manzini Hospital. Okay. There are three things maybe I can share on what has been presented with this case. Thank you so much. What I can see and from this patient, it's a patient with deep pain that we are seeing. I've got that the patient has been pointed at a gun by his own father. So that's trauma number one. And then the second gun he has got now is the cancer. So what I can pick from what is happening with the patient is that this patient is undergoing a lot of pain, and the pain the patient is that the most severe pain the patient is experiencing is not the physical one that you can treat with morphine. So this patient, I can tell there is no friend located around him. And most of the people who are seeing her, even the closest siblings, if I'm getting what you're sharing, is that they are not interested in giving her what she prefers. They are there to do what they want to do. And for that reason, she feels rejected by his or her own people. Thus, you don't want to see them next to herself. So the issue of rejection, the issue of being forced to do things I don't want. So it's another issue. So the patient is undergoing an intense emotional pain. The issue of being married, you know, in Africa, the ladies, once you get married, you want to sustain your marriage life to stay long. But then we are married, but it's complicated. You are not staying with your husband, you are there. It's another pain that has been there, that is already now showing up, that we need to take time and sit down and unpack that pain. Allow the patient to deal with that pain. Another thing what I'm seeing a broken family undergoing also emotional and spiritual pain, seeing their loved ones crumbling. So we may not treat the patient, but there's another patient that is too bigger, which is the family. So feeling them saying we want to take opinion number B, we want to do this, it's like they are not aware of the diagnosis itself, or else the prognosis. So I may say at this time, we need to look around the issues of, are we on the same page with the patient and the family? Is the family and the patient and the clinical team on the same page in terms of the patient's diagnosis itself? Are they clear? What is this? Is the patient aware? I'm aware also to say that the patient also can tell, my leg is going down or shrinking, but if we see it, it's not. Those are signs that we may find that what are the goals of the patient concerning his condition and the status quo of it. Now we are at advanced stage, end of life. What the patient prefers. So those are the things that can help us to understand and be able to share with the family. So because I believe the patient, there are things he values more now. So if I'm talking about what the patient values and what gives meaning and love, connection, you see, and the comfort at this point, it pushes me to spirituality and spiritual assessment. So we need either to use a hope or figure to assess the spirituality needs of the patient, to see what makes meaning to the patient now. What connects the patient to either God or people or the environment at this point in time. Now that the patient is at end of life, I believe you have shared with the patient that at this point in time, it's the end of life stage. And from end of life, these are the things that we can expect moving forward based on the disease trajectory. So then if it's that, I think we need to engage on the issues of family spirituality to see if what the family, the community the patient is located to is looking at, and see if there are conflicts in between so that we can manage those issues. And then after that, then the issues of end of life care being discussed with the patient so we can establish the overall plan of what are we going to do moving forward together with the patient. That's where we will end up seeing the issues of the home-based need or not. That's when the patient will decide if I need it or not. When we have sat down and unpack the plan of care at end of life, what end of life care will entail for her. So maybe that's when he will decide. I'm seeing a patient with financial issues here who is now dependent on others, and who is just open to auntie and brother and a few people inside the home. And if you may analyze, you will discover that these people she's connected to, they are not forcing her to do what you don't want, or else they are not judging her with anything. So there is a lot that we need to assess on that area of family spirituality, the patient spirituality. It can sustain the patient, especially now at end of life, to find what the patient would prefer, especially what he value more at this time around. I think the issue of morphine has been sorted, but I've still seen constipation still coming in, which might be because of mobility issues. Now the patient that is bedridden, and that is an issue that we need to consider morphine. But how we go to is to advise the patient, if we don't have in stock, to buy stool softeners. It can be lactulose or a liquid paraffin or castor oil, anything. And when we educate the patient that the reason we are prescribing or we encourage the use of stool softeners is to avoid the issues of hard stool, because now with the fistula, think of it pushing through a fistula, a hard stool, so it's going to be very painful. So I think one of the things we can look around is to encourage the patient, if they can get it on a local pharmacy, and then they can get it. It can help lower down the issues of constipation into a bit, because now the patient is already not able to move. And there's an issue of being bedridden in one position. So for a long time. So, you know, the issue of care, at this time around, we need to also to look around the issues of the true caregiver. How is the caregiver coping with the situation, and how best the patient and the caregiver and the team can work together in the care of this patient, you know. Some of these patients will find that even they have some smellies and all those things, and they are repulsive. You know, ladies, they don't want to be seen by their enemy while they are anguishing. So we need to see those issues. What I can tell from this is unhealthy family dynamics, which are affecting the patient. And in not very long, when the patient is gone, they will affect the daughter too. So this unhealthy family dynamics, and should any person have a serious illness in the family, they will then graduate and move to that level. So I will say one of the issues that we need to address while the patient is still, we are still looking at the issues of care, especially deciding on the comfort area of care and the issues of end of life care, is the issues of the unhealthy dynamics. You know, we cannot ignore that the patient is not willing to talk with other people and stuff. We need to dig much. There's more in that in response. Another thing I can share that we need to look also closer is the issue of patient autonomy. You know, the reason the patient refused to attend the meeting is because as a health facility, we then decided to say, we will look for ourselves which people we think can play better role. That's why the patient then said, it's your meeting, not mine. So I would say going forward, it helps to get the relevant people the patient needs. So even assessing the spirituality, you will find that she has spiritual people she can want even in a meeting to attend. So those issues, knowing where he gets the hope and the strength, can also assist us to help him. So I think the reason she refused to attend that meeting is because she felt we invited a person or people she didn't want them to see her at that state, or she don't find comfort in their presence. So I think those issues were the reasons why she then decided to boycott the meeting. So I think going forward, you will need to have a meeting again with the patient, whereby she will appoint the people whom she wants to be there in the meeting, and then we will share the veil of the meeting as to discuss the end of life plan. But now we are like this. Who are the people we can call for the meeting where they can support the patient? And then the issue of the sisters, I think once we can get those people to sit down with, we'll be able then to move forward and say, they can then talk with the sisters she don't want to come closer. That this is what the patient wants. These are the things that we talk of advanced care directive. This is what the patient wants. This is what she prefers at this end of life. So I think those are the issues that we need to understand. I hope the reason that maybe they were trying to look for option number 2 or second opinion is that maybe the issue of denial of that now there is no cure for what is happening. We're going to better palliate and manage. But at the end of the day, I believe they have to understand too that it's not about them only, but for the patient, what the patient prefers at this point in time, after the diagnosis has been clearly explained. I think those are the issues we need to do. So I guess the social worker can help manage the issues of this healing. You know, we need God, we need the ancestral part, we need this supernatural connection that we need. The spirituality can lift us up or can lift the patient from this doma he in, where she wants to be in isolation or be removed from the public or from the people whom we think he can help, or who wants from the isolation she's pushing herself in because of what she's going through, you know, this psychosocial therapy, I don't know if anything like that, that she needs. She needs some love, somebody who will show love. She needs somebody who will show that she's really there genuinely to support her, other than the family members who are there to push their agendas. I think the social worker needs can help at this point in that to heal the emotional part, because I think at this time around, as the mother is anguishing in this pain, psychological, emotional, and physical pain, the daughter, I don't know how far she is. So before even death can come, we can prepare for the end now. Looking at the issues of now, you are at end of life. What do you plan? Especially issues like preferences of a place of death. Should death come, where the patient wants to die? Those issues will help, because I'm seeing a conflict coming. If some siblings can fight the patient, forcing it to do things, what will happen if the patient dies? So those are the things I think we can help them to go through. And even the marriage situation, you know, family is always family. If the patient can die with this complicated marriage life, think of the daughter, what will happen to the daughter at the end? She will live in pain, in hatred of his father. So we need to look around also those issues so we can deal with them while the patient is still alive. Maybe the patient will say, why I'm having anger with these people, and this is how, and once she is open to discuss those issues, so we are then in a process to help the patient. So I can say, let's look around the social worker to sit down and unpack. If a family meeting is called, allow the patient to call those members and then stick to those members. Otherwise, he will have an attitude even towards us. It's like we are joining his siblings. We want her to do things she don't want to do. That's what I can share. Otherwise, the patient is at the end of life and terminal phase of care. So the terminal phase, we are looking around the spirituality of the patient. We are looking around. We are already preparing the family for the bereavement phase, and it may not be hard as it can be, while we are also preparing the patient to go through comfort and maintaining the quality of life. The issues of what really the patient is saying is of value to him now. What is his or her quality of life at this point in time? Thank you so much. That's what I can share. And say thank you so much, Imans, in hospital, to share such a wonderful case. It has been so helpful. I hope we've learned. And we hope as we are healing the patient, he will leave the world in peace if time comes. And we hope he will have made peace with everyone and get the best you can. And thank you so much to continue stretching your resources to continue with the home visit to see the patient while we are still missing the issue of home-based care. If ever the patient intends and say, I want to be seen by the home-based unit, and then that will be a good move too, to relieve the resources, because it's very difficult, especially if you are hospital-based, then to take off home visit at this point in time. Thank you so much. I guess this marks the end of our session. We have provided the feedback link. May we request that we click it when we exit, so that we may get your feedback. And thank you so much, Manzi Hospital, once again, for teaching us and showing such a great input you have done for the patient. And we are very glad. I think our next session will be on the 10th of August. So thank you so much. I see a comment here. Yes, may we kindly click the link there. We'll be coming back on the 10th of August. We'll be looking at. We'll continue with our series of communication. So thank you so much. Thank you so much. May we meet on the 10th of August. Thank you. Bye-bye.